So I am a pediatrician, as Stephanie mentioned, and we're all kids at heart, right? So some of this will be relevant to us, and some of it might be relevant to kids that you know and love who might be active as well. So you might go armed home tonight with some pointers for your kids and your grandkids, which is part of my message. So when we in sports medicine or pediatric sports medicine think about injuries that the kids get, and there's not, unfortunately, a really good surveillance system to identify how many injuries kids actually do get. There's surveillance systems in emergency departments to report on injuries that rise to that level. But beyond that, we don't really keep track very well. Even in doctors' offices, there might be billing records, perhaps, that can identify. But when we look at some pretty decent data recently from 2005, 2006, looking at the proportion of injuries, both practice and competition, the great number of high school injuries are what we call sprains and strains and contusions. Fractures are a smaller proportion. Younger kids get more fractures probably, but the high school age has mostly sprains and strains. And so when we do look at the literature, and we do have better estimates in the collegiate and high school population, really most of the injuries we see, most of my practice is what we call overuse injuries, overuse and overtraining injuries. But as I mentioned, the epidemiologic data in our country is pretty limited as to breaking that down further. But I think those in the clinical practice, the therapists here certainly would agree with me that probably at least half of what they see, if not more, other than the surgical conditions, are ultimately overuse conditions. So adults get overuse conditions as well. These are not, I'll talk about some interesting pediatric data, but some of the overuse conditions I'll talk about around the knee, primarily the knee, are very common in adults as well. So we define an overuse injury as what's called microtraumatic damage to a bone, muscle, or tendon that's been subjected to repetitive stress without sufficient time to heal or undergo the natural reparative processes. So as opposed to a more traumatic force that will fracture a bone, that's a traumatic injury or a single injury. These are sub-threshold repetitive forces, running, jumping, jogging, that build up over time, and because they're done too frequently or too intensively, the body does have natural reparative processes. And in fact, training in and of itself is a process of breakdown and build up. In order to build muscle at a microscopic level, the muscle fibers have to sort of tear and break down and then be rebuilt. Talk with kids about building muscle, and I always see kids, and even up to 25 I see patients. You have to tear down a foundation sometimes to rebuild a house. You have to tear down some of the muscle and rebuild more on. So there is a natural, even in bone, there's a remodeling process where bone resorption is then followed by bone deposition. And we hope you have more deposition and resorption to have more bone. So all of these tissues have that, but if there isn't enough time to allow that healing process to occur, the repetitive breakdown ends up leading to macro damage, and so you actually get the injury to the tendon, the bone, and the muscle. So when we see people who are active, we can classify clinically their grades of overuse injury based on whether there's pain in that affected area, sort of after activity, towards the end and then after, it may subside pretty quickly. And as it gets more severe, if you ignore those warning signs, the pain during the activity kind of come on as well, but it doesn't necessarily affect performance, doesn't stop you from completing the activity. Then there's further level of pain if you continue to run through these overuse injuries or perform pain during the activity that then does restrict performance, slows things down, or causes you to have to stop sooner. And then there's chronic unremitting pain even at rest. We hope we don't get to that point, but that's 4 gradations on one scale of overuse injury. The types of injuries that we can see that are overuse injuries are going to be mostly knee, but rotator cuff tendinopathy or multidirectional instability certainly is all ages. Little leaguer's elbow and shoulder, that's really for the growing kid who still has a growth plate. There's patellofemoral pain, which I'm going to focus on a little bit. And kids have these 2 unique conditions named after some surgeons from the turn of the 19th to the 20th century, Osgood Schlatter and Sidney Larsen Johansson. There's osteochondritis dissecans, there are shin splints, a whole category of pains in and about the shin related to lower extremity exercise. Sever's calcaneal apophysitis is a heel condition that again is in the growing athlete who has open growth plates or physes. And then spondylolysis or stress fractures in the lumbar spine, the low back, which also tends to be related to the growing adolescent or mid-adolescent. So PFS, or patellofemoral pain syndrome. easily the #1 diagnosis in my practice. I don't know how high it is on, some people are nodding in the back, so one of the major reasons that people will seek care at a practice like Freddie. Pain is with or after activity. Pain is fairly non-localized to the front part, the anterior part of the knees. Sometimes pain will be more going upstairs than downstairs, but there's pain with stairs typically. Pain can come on with extended periods of seating or flexion, so they talk about, in our board exams in medicine, they talk about the theater sign, so the pain comes on after someone's been sitting in a movie theater for too long. I ask the kids when they come in, do they have pain after a long car ride? And then sometimes the knee has a sensation of giving way, but it doesn't truly completely buckle or give out the way we might think of with like an ACL tear, traumatic injury. So this is a very common cause of knee pain. This is what we see frequently. And what it ends up coming down to is what I consider a whole series of overuse injuries to various tissues from, this is a knee with the thigh would be up here, or the hips would be up here. Here's the end of the thigh bone, the femur, the tibia or the shin bone, the kneecap in front of the patella. And it's all about, sort of all about forces and vectors. I used to teach high school physics, and so these joint reactive forces are really fun, and you can do that with the high school physics students. But patellofemoral pain syndromes can start up in the quad muscle and the quad tendon, which attaches to the patella. So you can have quad tendonitis. This is the patellar tendon. You can have patellar tendonitis or jumper's knee. Kids will have a couple conditions I'll show in a second. The more common problem is around the patella itself, and the way the patella sits in a groove on the end of the femur here, the trochlea. So if there's force coming from above and there's force coming from below along the patellar tendon and the quad tendon, there's a resultant joint reactive force which sort of drives that kneecap into the groove. If we look at it on end, it's actually like a train sitting on a track. That may be the underlying source of all of the irritating problems for this, what used to be called Chondromalacia Patella, a term we don't use anymore because we don't actually see the changes in the cartilage that Chondromalacia Patella suggests, but that was the term that we used a lot 10, 12 years ago. And ultimately it ends up being related to an imbalance in the flexibility of the muscles in the back of the leg, the hamstrings, some tightness in the quads, and more, the physical therapists have taught us that ultimately where it all starts is in the hips and the core. And we, for many years, were looking at the feet, and we're putting arch supports in the feet, and that's not bad and all, but really the control of the knee joint starts up at the hip and the core, and they know that working in the gluteus and the hip control muscles really is what helps control this knee, and helps overcome some issues. Kids, younger kids, if you have kids or grandkids who've come home and told they have Osgood-Schlatters, how many kids or grandkids have had Osgood-Schlatters? Have you heard that term before? Many guys. So that's this growth plate here on the proximal tibia, the nearer part of the tibia. This is the tibial tubercle, the spot right up there. That when kids get this condition, they have a little bump that looks like the old pop-up turkey baster on the Frankfurt turkeys. If you tender there, it hurts when they kneel down. And Cindy Johansson, the other end, it's on the end of the patella, the kneecap itself. All related to the fact that this is groin bone, and there's an area of softer bone, that the tension of the tendons I showed you on the drawing essentially pull the bone away and cause irritation. But it's all the same mechanism. As they outgrow this, they may develop a more common patellar tendonitis or the overload patellofemoral pain syndrome. So this is what's known as the miserable malalignment syndrome. That may be some biomechanical disadvantages that predispose kids to, or anyone to having anterior knee pain syndromes. And this was most specifically described, or is most specifically described for women and adolescent females, for whom the wider pelvis and some what's called femoral aneversion, which allows the knees to buckle in a little bit. This is univalgus, which causes a little bit of knee buckling as well. Some hyperextensibility or hyperflexibility, hypermobility was felt to be a contributing factor. All of these factors, external tibial tusion, the classic positioning is something like this. And you have someone running a lot, and their kneecaps sort of slide back and forth. The Q angle is implicated for a long time, tibia there, and pronation of the midfoot. Some of these in individual studies bear out as factors to identify and address in rehabilitation when someone has overuse pain or overuse tendonitis or injury. But I tell you, if you go to a high school gym or college gym and you line up all the kids, I bet, because the studies haven't ever really convincingly shown us that they're all predictive risk factors for pain, you might find just as many kids who don't have pain with running with this alignment as who do have pain with running with this alignment. So, I'm jumping ahead of myself a little bit. No matter what the case, if the kids get pain or if we get pain, there's pretty common treatment principles for all overuse injury. Really, no matter what part of the body, we need included. So you want to protect from any further harm or injury. Sometimes that involves bracing, but more often than not, it involves reduction in the amount of training or activity that's caused the problem. That's relative rest as well. Ice is always a friend, compression and elevation. So the good old rest, compression, elevation. Sometimes we use medications. Short courses of non-steroidal anti-inflammatories can be safe in short courses to decrease inflammation and pain. We want to make sure we maintain range of motion or gain back any range of motion. And our colleagues in rehab medicine can utilize modalities, including strength training. So PRISMS is sort of an overall approach that we can bring, we can suggest to people, and we can work in collaboration with folks like school athletic trainers and good local physical therapy, of which Freddie, this group is one of the better ones, but we're actually blessed with a host of good physical therapy groups in town, quite frankly. It's a nice competitive marketplace for you, Bill, right? Which drives the quality up for everybody. So it's good for us, it's good for patients. But, I think when we as pediatricians and child health professionals look at these factors and we see kids in our office, and it doesn't always translate into kids who have this syndrome have pain, and others who do have the syndrome do have pain, and others who don't have any of these syndromes. We started to think about, well, what can we do? We always want to prevent things. We're famous for immunizations. So we've eliminated polio and measles and all kinds of dread diseases with preventative strategies like vaccines. And public health folks also like to think about preventative strategies. And we'd be better off, we're a heck of a lot better off preventing injury than trying to rehabilitate them. And keep people out of our offices, keep people out of this place, unfortunately. But how do we approach that? So the public health framework looks at the athlete as part of a system, and the system involves energy being transmitted to the athlete or to the person, and that's what ends up causing the injury, repetitive reception of energy or dissipation of energy. But there's a lot of other factors at play. There's the physical environment, there is the family structure, there is the social environment, and so I was fortunate to participate in a consensus panel put together by the National Athletic Trainers Association in 2011 that really dug into the scientific literature to see if we could identify true causal risk factors for overuse injury in kids, but some of these translate to adults as well, to see if there was anything that we could put out there as best practices. And there wasn't a ton, unfortunately, but we came up with about 7 major categories. One is this injury surveillance. So part of the reason why we might not be able to identify some of these risk factors, so to identify a risk factor, you have to say, how many injuries are there in that group of high school students who have miserable malalignment? And how many of those kids with a malalignment did get injury versus don't? Because we don't have any real good national or regional collecting system to identify who ended up getting injured, we can't sort of connect back those who got injured with whatever risk factors, whatever predisposing factors they may have. So the fact that we go around saying that we don't identify risk factors is partially because we don't have really good injury data to suggest in order to follow who gets injured. But I do believe that there's some factors we're going to talk about that are important for all. We talked about having a good pre-participation physical examination, and certainly if you were to participate in the gym, the RVC, one of the things they make sure you do is you've been signed off by a physician saying that you're okay to participate. A big part of that, of course, is that they don't want you dropping dead on the cardio machine so that your heart's okay. But there are other factors that we could look at too in terms of musculoskeletal risk factors to help connecting. We want to identify those risk factors for injury. We want proper supervision and education, both medically and coaching-wise. Sport alterations, training and conditioning programs, and delayed specialization. And I'm going to talk especially tonight on about 3 of them: the PPE, risk factors, sport alterations, training and conditioning programs, and delayed specialization. So, as I just alluded to, many states, most states will require for schools, and as I said, many athletic organizations and many fitness centers will require some sort of a clearance from a medical professional before you engage in intensive physical activity, sports PEs or something. I do all the time. And one of the things we try to emphasize is that in addition to making sure that someone doesn't drop dead from a heart attack or from a cardiac, an undetected cardiac condition, is that we start screening for musculoskeletal factors, flexibility, range of motion, strength as best we can. And these hopefully take place, hopefully, far enough in advance of the competitive season that we can, if we identify an imbalance or something we think might predispose them to injury, we can then refer them on to a rehabilitative specialist to address that deficit prior to engaging in training. More often than not, they show up the day after physical activity has started or the day before, and the coach won't let them on the field come August for football season, and we have to do a pre-participation evaluation at that point. And anything we may find at that point is already sort of lost. So we did identify for at least the growing athlete some potential risk factors that could be investigated and might be places that researchers could actually do some studies to examine. So at least in the younger age athlete, there's cartilage at the growth plate, which is more susceptible to injury. And the adolescent growth spurt does probably increase the risk of injury because of the rapidity of growth at the bony ends. But these intrinsic factors are probably factors that are true for any athlete. So there's intrinsic and extrinsic. So history of previous injury, sort of malalignments of any joint, but particularly around the knee, as I suggested. For women, the menstrual cycle has been investigated extensively to see its effect on injury. There's psychological issues, muscle imbalances and flexibility, muscle weakness, which I don't know why we differentiate from imbalances, but you can be strong in muscle groups but not balanced strong. Instability, and the level of competition, age, height, gender, Tanner state, which is a growth factor, laxity experience, and then the extrinsic factor, training recovery, equipment for technique, again, psychological issues, training errors, environment, deficiencies, and conditioning, all of which were sort of examined as potential ones, and not many of them sort of fell out as being real risk factors. If anything, for the knee, this is level C evidence. When we grade scientific evidence, we go from A, B, and C. A is like randomized controlled trials, which all of the drugs we take should have gone through randomized controlled trials that are approved by the FDA. Level C is largely consensus, expert panel consensus. You know, a bunch of people like me sit together in a room and agree this is right, this is good. We know this to be true from what we've seen in our practice. But there are some profiles of overuse injury prone male and female young athletes. The taller boys, the endomorph body structure, which is a little bit thinner, less static strength, more explosive strength, decreased muscle flexibility, high degree of ligamentous laxity, this large Q angle, which I sort of alluded to earlier, which is the angle between the hip out here and the center of the patella, as well as the ischium where you sit on. But really, we see it sort of clinically by Q angle really is sort of the degree to which the knees are not. It's sort of really a simple take-home view of what the Q angle is. Girls, tall stature as well, decreased upper extremity strength for overuse, upper swimming injuries, less static strength, more explosive strength, high limb speed, increased tightness, increased laxity, so both. So if you're too tight, it's not good. If you're too loose, it's not good. Greater leg length discrepancy, pronation, which is the flat feet when you stand, and a large Q angle again. The wider hips that women have, which sort of teleologically is associated with having a larger birth canal, there's just by definition usually a larger Q angle. So baseball has actually done a fair bit of research. Dr. Andrews, anyways, in Birmingham has done a fair bit of research looking into the causes of Little League shoulder and elbow, as well as older athlete rotator cuff problems and the predisposition to the Tommy John surgery, the ulnar collateral ligament tear. And there's lots of debates. There's been lots of debate over when can kids throw curveballs, should they throw curveballs, should they throw breaking balls. And whenever they do the research, yeah, probably throwing a curveball that poorly is bad for the torque that's on the elbow. But over and over again, it's when the kids throw with arm fatigue and pain and they pitch too much is when they end up in trouble. It's pitching too many times. It's throwing the ball too many times in a week or a day or a month or a year. And so baseball has had several iterations now, and there's even a website that coaches can go to of what is the right number of skilled throws a week that kids can throw. And the little leagues and different leagues adhere to different rules and pitch counts. Hopefully the coaches and the umpires, but mostly the coaches have to enforce those rules. But this started to make us think, oh, well, maybe what it comes down to is volume. So arm pain and fatigue, they said consider some of these other factors, the midfoot hyperpronation, the leg length discrepancies, which can be detected on a good screen, a good movement screen, and certainly physical therapists can identify these factors very nicely and address them. And they can even then go through training and conditioning programs that, as I alluded to, improve neuromuscular control, balance, coordination, endurance, flexibility, and strength. But you're going to have time to do this. You need 6-8 weeks before seasons begin, before you engage in competitive participation. Otherwise, you ramp up too quickly, and it's probably that ramping up too quickly or too much volume. So what I was going to allude to is that ultimately it probably comes down to volume is so much the primary factor in causing overuse injuries that the other factors may be important. If we could ratchet back the volume, then those other factors may then be able to show themselves as being scientifically or statistically significant factors. And we can hone in on them a little bit better, but it's sort of trying to find signal through noise. There's so much noise, or the needle in the haystack. It's just so much of a factor of volume. And I have a few slides that show what I mean by that. So stress fracture is the bony overuse injury, ultimately. And unlike other overuse injuries, although ultrasound is now showing more and more promise, overuse injuries are hard to sort of have a gold standard definition of. You can't see them on X-ray in terms of tendinitis or bursitis, those sort of inflammatory conditions in the soft tissues. But bone, you can end up seeing a stress fracture. You can actually see it on a scan or an X-ray. Stress fracture is one of the better overuse injuries to study because it has a firm endpoint. And so we studied stress fractures in about 6,000 children, about 5,500 children of nurses who participate in the Nurses' Health Study. So this is the large epidemiologic study that's been going on in Boston for ages, and it's one of the ways that they identified that estrogen doesn't protect the heart that well, and questioned the prescription of postmenopausal estrogen because of the benefits. So this is an ongoing study, and they enrolled the kids, the children of the women in the Nurses' Health Study, and we were able to question them on their injury rates. And we were actually able to ask them how many weeks of many hours a week of moderate to vigorous physical activity they participated in. And somewhere around 16 hours a week, their injury rates, down on this low end actually, less than 1 hour a week, their injury rates, self-reported stress fracture was higher. And I suspect that's because kids who weren't very fit started to do too much too quickly and developed a stress fracture. And then the other kids on the higher end of the spectrum really started to shoot up. Around 16 hours a week was clearly a time at which this risk of stress fracture increased. So we ran some statistical models, about 80% increased risk of stress fracture if they were greater than 16 hours a week of activity. With high impact activity like running, cheerleading, or gymnastics, 5% overall, or 12% increased chance of stress fracture for every hour per week of running or cheerleading or gymnastics in this group. Older kids, those who are post-menarche, having had their first period, so basically those kids who are post-pubertal also more likely to have this injury. But the hours per week ended up falling out as the biggest factor. Talked about pitch counts, and swimming. USA Swimming has also made some suggestions on the amount of time and duration and volume of swimming. That's another sport that actually measures its activity in a quantifiable way. So pitch counts are a number you can count. You ask any swimmer, they'll know their yardage or their meter, how much training they do on an actual quantifiable. Otherwise, you're dealing with time. Time's challenging because you're not necessarily active during that whole time. Runners, you can get mileage as well, and that's not a study that we're involved in, but you can do mileage with runners. But outside of those three parameters, mileage, yardage for swimming, and pitch counts, it's hard to quantify. So, in terms of volume, one of the recommendations we came up with, because what we see in a trend, and I think we all see this, is kids now participating in single sport, intensively training and specializing from a very young age, and playing soccer 4 seasons a year, starting at ages 6 and 7 and 8. And maybe in some cases also doing ice hockey 3 seasons of the same year that they're doing 4. So we've suggested multiple sports and recreational activities throughout the year, and at least 2 to 3 months off each year from a single year-round sport. And part of that was prompted by a questionnaire we were able to do some high school athletes in Akron, Ohio, that looked at the number of seasons of sports that they were participating total. Some of these kids reported 11, 12, 15 total sports seasons a season because they could be a year, because they could be participating in more than one sport each season. So they're 4 seasons a year, and some of them could be participating. So this also showed that when they adjusted the odds, some of these weren't as significant, but ultimately girls had more overuse injuries than boys, but there was about a 40% increased chance of overuse injuries if they had any 4 seasons of participation versus less than 4 seasons. So ultimately, if they took a season off a year, if they had 4 seasons, they had 40% chance more 40% more chance of having an overuse injury. It didn't end up making a difference if it was 4 of the same versus 4 of different. It really was having that 4th season off that really made the big difference for this group. And some other groups have started to look at sort of scheduling, over-scheduling as a risk factor. And these are actually several sports medicine, pediatric sports medicine practices around the country. So all they could look at, they don't look at kids who aren't injured. They only get injured kids in their practice, as do I. So they had to compare injured, overuse kids versus acute overuse, acute injuries in their sample. And they looked at some factors, but the one that was interesting to me was there are 2 that ended up being important that parents reported. So too much playing time without enough rest was a risk factor for overuse injury. And the number of practices within 48 hours before the injury, the more the practices, the more injury. Another one that came up that they didn't put in their title, in their table, but when you read the paper, is that sleeping 6 or fewer hours the night before the injury was associated with all fatigue-related injuries. So sleep is an important factor as well, in addition to not overscheduling. So the American Academy of Pediatrics, to which I belong, has a statement on overuse injuries, overtraining, and burnout. And a lot of the same themes have come through from this group. And this probably is true, I believe, for all age athletes in terms of preventing the onset of these overuse injuries. And I think one of the things that we weren't able to do with our stress fracture study, but I'd like to be able to, is to measure not just the total volume, which is, I think, an important factor, but the rate of increase. I think we classically see the third week, so this place will get busy again. Well, it's busy all the time, but you'll start seeing high school athletes late August, early September, maybe mid-August, late August, because they'll come in getting ready for soccer, cross-country, football. They didn't necessarily train all summer long, so some of these kids aren't overtraining here, and some are going to try and get ready too quickly, and they're going to develop stress fractures, shin splints, patellofemoral pain, Seaver's disease, and jaundice season 2. They're going to see it that time of year because they ramp up too quickly. So one rule of thumb we use is increase your training volume total. It's for all of us probably true. No more than by 10% total each week. Again, easier if you're doing distance running because you have a clear amount of volume. Harder when you're just doing time-based. We talked about the 2 to 3 month break from every sport. Only being on one competitive team each season. Try that. Special precautions for the youngest athletes, especially when they're in these compressed multi-game tournaments. And we worry about burnout, not just burnout of the tissues, which is an overuse injury, but overtraining syndrome, which is a series of psychological, physiologic, and hormonal changes that do result, ironically, while they're participating in sports, in decreased sports performance. In adults, it's fairly well diagnosed, or at least described in adults, that overuse or burnout syndrome can be associated with chronic muscle or joint pain, there are personality changes. There's actually an elevated resting heart rate. Conditioned athletes who can drive their heart rates down 60s, 50s, 40s in young athletes, they have these elevated resting heart rates. There's something about their sympathetic tone, and they get decreased sports performance. This is a constellation that would be sort of described as burnout. With kids, it's harder. They get fatigued, they have lack of enthusiasm about practice or competition, difficulty with successfully completing usual routines. Well, that's normative behavior for teenagers, so that's harder to pin down. But we do worry about that. And so as far as prevention techniques, and all of us could probably benefit from this, keep workouts interesting, keep age-appropriate games and training, keeping it fun. Take time off from organized or structured sports participation 1 to 2 days per week, allowing your body to rest or participate in other activities. Permit longer scheduled breaks from training and competition every 2 to 3 months while focusing on other activities and cross-training, so keeping the body fit by not just always using the same muscle groups in the same way, but cross-training to use other muscle groups in different ways. Focusing on conditioning, so you don't lose overall conditioning. And then wellness, and teaching athletes to be in tune with their bodies, to appreciate those cues, to slow down, alter the training methods. Teaching kids this so that they can do it better when they're adults. Because I would venture to say that part of why any of us show up in a practice like Bill's and the group here is because we don't listen to our cues, and we do go through those 4 stages of overuse too quickly, and we don't listen to the warning signs necessarily when we should. And really, this is my take-home point for kids especially, but maybe for all of us when it comes to our activities that are outside of required work activities. And if it's not fun, why do it? So I think I got it done in time that I'm perfectly happy to answer some questions.
I have a question. If I flex my knee and it makes a loud pop, what does that indicate?
Does it hurt?
Yeah, a little. Not so much when it pops. It hurts at other times. But
so I tend to dismiss or diminish popping. And again, this is the scope of age range of my practice. Popping makes us worry, perhaps, that there are degenerative changes involving the meniscus that could be causing that sound, especially if you get more of a catching or locking, if the pop is associated with the fact that you flex and you have to overcome it. Popping, sometimes we worry about the kneecap, that patellofemoral articulation may not be sliding in the groove, sliding in and out. And, those are probably the 2 biggest factors. But if it's pain and there's no swelling and the pain doesn't really persist, it's worth getting checked out. But I don't tend to worry too much about popping. I try to, and the reason I say that is because part of my message usually is if you're not really getting pain or swelling, and your joints aren't getting stuck or locked on you, so you're not getting stuck in one position. Part of your self-medication is to keep moving. Just to some extent, be a little bit blissfully ignorant of the creaks and cracks that are going on in your body. So just keep on moving. Yes.
What does it mean if your knee hurts when you haven't moved it for a long time? And then it's fine when you get moving?
So it could be normal. So as I suggested, this patellofemoral knee pain, it could be a part of the normative. I think, again, that is one of the ways, and I'll let the audience jump in, not the audience, but my colleagues in rehab jump in. Yeah. Warning signs for pain, for me anyways, are pain which wakes you from sleep at night. That's a warning sign for pain. Pain that's associated with fever or weight loss or chills or other signs that might be concerning for infection or cancers. And then bony pain tends to be more related to when you're weight bearing. I sort of take pain which exists when you're at rest but gets better when you're moving as your body's signal to remind you to keep moving, keep moving. But I'm not examining any of you, so I'm not going to say that what I'm saying replaces your individual healthcare provider's advice. But pain the other 36 hours, the other rule that I use as a rule of thumb, so those other warning signs are pain which wakes you from sleep at night, pain which is very, very severe, obviously, pain that's concerning on weight bearing, and those other signs, fever, weight loss, loss of appetite, things that make us worry about infections and cancers. But then there's I use a 36-hour rule roughly, so that if you've developed some discomfort by being active, and it's sort of that overuse pain that it's sort of towards the end of being active, and it persists for a while, and you use ice, and you use relative rest, and you might even use a short course if your doctor say it's okay for your heart and your stomach to use a little NSAIDs. if you can take 36 hours of rest, using the ice and using the NSAIDs, so it happens in the afternoon, and the next morning it's still there, and it's still aching, maybe getting a little bit better. Another 24 hours of that ice and NSAID approach, or ice and rest approach. If it's there the next morning, 36 hours later, that's when I said, call me, call your doctor. Rough rule of thumb is a 36-hour rule that I use. The pain that makes you get off your butt, I think is good pain. But, Bill?
I mentioned there is a thing called myofascial that actually we learned about and we'll talk about it. That relates to in some cases, people that have pain at rest. They seem to have a really clear breathing rise. That can be one of the reasons maybe some.
And you'll talk about that in the context of the needling, how that can be helpful.
Yes.
Yeah. And again, I very simplistically think of it in the way, in some ways, that myofascial pain is in some ways your body telling you that it's sort of gotta get moving. There are little nexuses of nerves and muscle endings that are just wanting to be more stretched out than they are. So keep moving.
May I ask a pediatric question?
Oh, please. Save it.
If a child is youngish and growing up, I'm thinking of the male at the moment, growing up through that adolescent period of time, I chuckled a bit when I saw that you suggested they take several days off from doing certain things, and probably you know as well as I do that that's probably not going to work in high school, etc. So do different children have different points of time when they might be developing differently, so they're more able to be injured?
Yeah, we definitely think that in that time of maximal growth, the growth spurt, does put them at greater risk of developing injury because of the imbalances between the bony lengthening and the tendons and muscles, which are not keeping up in that lengthening phase. They're also developing less flexibility as they transition into adolescence and they feel the effects of estrogen and testosterone. And the third factor is, well, the growth plates themselves are slightly weaker than the bone, that the growth plate, that it's growing so quickly that the cartilage at that growth plate is probably a vulnerable spot. But then the final factor is, as they go through their growth spurt, they get a much larger bony volume. And that bony volume takes a while to then get mineralized. So kids sort of in bone density terms, and I think this audience is aware of bone density screening and DEXA scans in postmenopausal age. But these kids will have a relative dip in their bone density because their bones get bigger, but there's a little lag for the calcium to sort of fill in that matrix and turn it into as dense as it's going to be. So there's sort of a relative little drop in their bone density, and then they accelerate back out. They gain 25% of their total adult bone mineral within the 2 years around their peak growth spurt. But as they're having that growth spurt, they sort of have a period of vulnerability. So for sure, we worry about that age. And I'm making this pitch so that you'll go home and tell your grandkids and your kids that they really should try to have their kids have at least 1 or 2 days a week off from competitive athletics. Try to have only one sport a season, and try to vary the sports that they do year round. Because I shouldn't be in business as a pediatric sports medicine doctor. There shouldn't be enough business for me to do what I do. Sports shouldn't cause pain the way it does, the way we see it in the society. And the guy who taught me a lot of what I know, Lionel McCaley, who created the first sports medicine center in the country at Boston Children's Hospital, noted that he started his career in 1970s, 1960s as an orthopedic surgeon. He saw kids who broke their bones from falling down. That's what he saw. Now, 90% of his practice, like mine, is kids who are doing too much of what they like to do and are breaking down the soft tissues in a microscopic way, not to mention the ACL tears, et cetera, et cetera. So for sure, it's a vulnerable age period. And we want them.
Make a suggestion for you then?
Please.
How would you and Bill Freddie like to go and share all of that knowledge with local folks in schools and colleges and help the
We're always willing, right? And we've been to some of those places. I don't know if you
Good.
have, but yeah, we've been to some of those places.
I have a question about after I've been hiking up for, I don't know, an hour or more, it's when I come down that I get intense pain behind my knee on the outside. I mean, sometimes where I can't even,
So people, so up is obviously hard, and think, oh, I'm climbing, it's obviously going to take a lot of toll on my muscles and my quad as I'm extending. But you also have to, as you go down, you have to absorb all of that force, and as a therapist can explain to you later, that's what's called eccentric loading of the joint, which is much harder on the muscles than the concentric contraction of the muscle, that you're shortening the muscle versus lengthening the muscle as you're contracting it. The other thing I'd have to say, that one of the things I said, when I'm teaching residents and other healthcare professionals, one of the little pearls is pain going up tends to be more patellofemoral pain. Pain going down might make you start to think about the meniscus a little bit more. And if you have pain coming down, in your specific case, you might consider someone evaluating you for a lateral meniscus tear or degenerative condition. But in generally, down is harder than up. And you guys can talk about when you train people, one of the things you really, when you're going to work them hard, you do eccentric loading and even things, ellipticals now. Machines have gotten into both forward and backward phases to balance that. But one of the little pearls, sometimes going down pain, if it's persistent in one single location, might make you think meniscus. Even then, meniscus doesn't always require surgical intervention. It can be mitigated well with good rehab, such that although the tear may not be gone, the mechanics of the joint become better, so that it doesn't load the meniscus in such a way that causes pain. So first step could be an evaluation with one of these folks at that point.
Thank you so much, Dr. Loud.